All right. All right. Well, good morning and welcome everyone joining us online for our second virtual chat on COVID-19 with healthcare professionals all around California. Today we have the honor and privilege of learning from Dr. Boden-Albala, who is currently the Dean of Public Health for UC Irvine. Our virtual podcast today is brought to you by the Medical Certificate Program of Beckman High School in Irvine, California. We hope today's conversation will be educational for whoever is watching online, and that throughout this virtual chat series, students can tune in anytime to get further educated on what's going on in healthcare right now. Hundreds of students at our school have shown interest in tuning in this morning to our talk and have submitted questions to us in which I will be asking Dr. Boden-Albala today. For the students who are joining us right now on YouTube Live, there is an option for you to comment in the comment box in which you can submit any questions you have throughout our talk. After I finish our pre-submitted questions, I will then refer to our new comments being submitted online. Without further ado, welcome Dr. Albala. How are we doing?
Great, thank you so much. I'm really excited to be here.
Awesome. So our first question is, can you just briefly introduce yourself and share with us your current role at UC Irvine and just a little bit about your personal life?
Sure, great. A little bit about my personal life, is that right?
Yeah.
So I'm Bernadette Boden-Albala, and I'm new to UCI. I'm the founding dean of public health and new to California, actually. I moved in here less than a year ago. If you can't already tell by this heavy New York accent, I spent my entire life and career in New York, born and raised, and I got my PhD in epidemiology at Columbia University, and then spent another 16 or so years there, worked my way up downtown New York to Mount Sinai, and then ended up starting a school with a great team at NYU, the College of Global Public Health, and was recruited out to California to really build a public health presence here at UCI and really partner with our Orange County community. So two things I'll tell you just very quickly personally. This is the longest I've spent not on a plane in a very long time. I love global health. I'm a real traveler. I do a lot of research in Africa, and if people want to ask me about COVID in Africa, I'm happy to talk about that. Love to travel, and really love, sadly, kind of, but interestingly, infectious disease epidemiology.
Wow, that was awesome. All right, so the first question that the students have is, how did you first get interested in epidemiology of all the fields and public health?
So it's actually a really good story. So I was always interested in biology and on the sort of the intersection of biology and human behavior. And so my undergraduate degree is actually in biology and in physical anthropology. So always interested in the way in which people impact health, and they really do in so many ways. And I think COVID is a great example of that. But I really liked biology, and I wanted to go to medical school, just like what your parents want, I'm sure many of you to do. And so I ended up doing some interesting work at Albert Einstein College of Medicine in the Bronx, doing work on cardiovascular disease, but at the cellular level. And I met my husband there, and we got married. And I was actually in a graduate program going towards a PhD in cellular biology. And, a year or two later, I was pregnant with our first child, and I got a visit from environmental health saying I could no longer do the kind of work, because I was working with isotopes. And so this is really a cool story. So I was going to have to do something else during my pregnancy, and there were a couple of options. And don't even calculate my age, please, when I tell you the rest of the story. So there was a really interesting problem in communities in the Bronx and in New Jersey, and there was something that they labeled HTLV3, which very soon became HIV. And so I ended up getting involved in one of the first pediatric AIDS hotline, and it was really really interesting. So that was my real first epidemic, was HIV, and I was there 2 or 3 weeks and totally learning about public health and HIV and all of the problems, everything from people who had HIV being evicted from their houses, to understanding all the different the transmission, to really living through an epidemic, not of as great a proportion, but clearly a terrible epidemic during a time when we really didn't know that much about what the virus was or how it spread. Sound familiar? And there was a lot of fear and stigma and anxiety and discrimination based on that. And so I never looked back. I never went back to my cellular physiology lab, and instead I enrolled in a program in public health at Columbia University.
Wow, we are in for a treat. If you cannot tell already, she has so much great experience to share with us, and thank you so much. Since we're colleagues, you've asked me to address you by Bernadette, so
Yes,
I'm going to go ahead and call you that from now on. All right, so Bernadette,
great.
can you tell us a little bit about just your brief experience? I know you touched on it, but just a little bit about your brief experience with pandemics throughout your life. So I know you
Yeah.
touched on the AIDS one, but go ahead and share a little more about that.
Yeah, so you should just know that HIV got me really interested in understanding infectious diseases. And in fact, my first graduate degree was a master's in public health in tropical medicine. And in my mind, I wanted to go to low and middle income countries and really help to, stop the terrible spread of diseases like malaria and dengue, schistosomiasis. And so I really brought together the parasitology, microbiology, and really wanted to study that with, again, human behavior, because human behavior is the reason that not all diseases are experienced the same way. And so I started to do that, and I have a kind of a sad story in the middle of this whole thing. So really working with HIV and AIDS, my daughter was born. I continued to do that work and go to graduate school, and my sister ended up being diagnosed with HIV, and actually passing away during that whole AIDS epidemic. And so, that was a lot for me. And I had a really good, sort of great skills in epidemiology, and we can talk about that, and study design and methodology. And so I decided to kind of move my work a little bit, to working on some chronic disease, and to finish my PhD, or I have what's called a Doctor of Public Health, a DRPH, which is really very much a degree that looks at sort of methodology, but it also adds a kind of leadership role and to public health. And so for a while, I was just doing work on stroke and cardiovascular disease epidemiology, but in communities. And I got very involved. I wasn't in Africa. I was in the United States. I was in New York City. I was being very practical about my life, but working with different race, ethnic populations, folks that were coming in from South America, from the Caribbean, from Africa, from all over the place. And so a lot of my work was kind of looking at the epidemiology of different diseases. And so continued to do that. And then interestingly, because I had been working with different race, ethnic populations and focusing on this issue of disparities, something we see a lot of in COVID, right? So we're seeing that African Americans and Latinx populations seem to be disproportionately experiencing the severest symptoms, including ICU admissions and death. for COVID. Why is that? And so my work has really been in in race ethnically diverse populations, trying to understand why different populations experience the same virus or bacteria or other disease entity in very different ways, resulting in differences in death and in disease and in disability, and really kind of changing the trajectory in a person's life and in a population. And so interestingly, at some point while I was in New York, because I had had a lot of work in different race ethnic groups, I got a call from the National Institutes of Health. I had been getting funding from them, and they said, maybe you can help us. We have some work that needs to be done among Alaskan Native populations and in cardiovascular disease, but they also have some infectious disease issues, and we need some help. And of course, I said, well, I'm a girl from New York. I'm a New York woman, a pretty aggressive New York woman. What am I going to do in rural Alaska? And they said, well, would you just get on a plane and take a look? And so this is a really important story. I get on a plane, right? I don't camp. I like a nice hotel, and so I get out there in rural Alaska, and it's so interesting. I don't know if you any of you have been, but there's a number of tribal entities up there, and so it's taking what we call community participatory research and really working with communities to try to solve their health problems. And it was a wonderful, eye-opening experience. The first year I went the first time in August, and I said, okay, so we're all set. This is the trajectory, the design of the intervention, and everyone nodded their head. And I went back to New York, and I'd call on the phone and I'd say, what's going on? And so I'd get back on a plane. And that first year, I must have gone 6, 7, 8 times in the middle of the winter in Alaska. It does really get down to -40. But the important thing is that I needed to be there with these communities to establish trust, so that they knew that that I was really going to do work with them on this, not just come in, tell people what to do, and then leave. And a really important part of public health and epidemiology, if you're interested in this, is not only will you be looking at diseases in human populations, but you have to work with those communities, with those populations. And the only way is to really partner and to gain trust. And so part of that work, even though we're talking a lot about science here, part of that work is really understanding human behavior, how people handle certain things. So there were some problems in Alaska where people were getting terrible, staph infections, and nobody knew why. And it was cold outside, so people weren't interacting. And only by understanding and going out there and realizing that this sort of outdoor home-built sauna was a key component to, there's sort of like a sweat box, key component to faring well in Alaska, in these rural communities. Did we understand that what was happening was, one person would have an infection, and then they'd be in the sauna and they'd shower and they'd leave, and then maybe the next day somebody else would come in and they'd be barefoot and they'd have an open cut, and so then there was this infection. And so this is just an example. If you just did this from like armchair epi, you wouldn't understand that behaviors are so correlated with how diseases exhibit themselves. So there's just another example. And after working in Alaskan Native communities, even though they're in the US, a lot of their health issues are very globally important. And so I ended up doing exactly what I wanted to do years ago, which was then getting involved in working in the Caribbean, in different communities, on different islands, and then doing some really interesting work, which I'm still continuing to do in West Africa. And so you asked me about what other kinds of epidemics in my life. And so I ended up getting involved, heavily involved with the World Health Organization and with UNICEF. And there was a lot of different things going on. But the big problem, and I don't know how many of you know about polio, and if you don't know about polio, you should go right now and look it up. It's a very interesting disease, very sad disease. But we had almost eradicated polio, meaning we had almost gotten rid of polio as a major disease. Now, polio is interesting for a couple of reasons. Most of the people that get polio are asymptomatic, and so you don't know it. The tip of the iceberg, only, I think it's like 1 in every 100 people who get polio, their children often get this, what's called acute infantile paralysis. They're paralyzed. And I think we know polio as a disease that's associated with paralysis. So most people that get polio, that when there was no vaccination, had no symptoms or maybe some gastrointestinal symptoms. And so polio would sort of spread wildly in a community, and then somebody, a child, usually under the age of 15, would end up with this paralysis. And so what's happened is that we have a vaccine for polio. The vaccine is a lifelong vaccine to eradicate polio. And some of the things I know we want to ask is, why can't we have a vaccine for COVID? How can we eradicate COVID? What can we do? So polio is an interesting example. So if you're vaccinated against polio, it's almost really a lifelong vaccination. Okay, so once you have polio, either because you've acquired it or because you've been vaccinated, and everybody in this Zoom room has been vaccinated against polio, you actually have lifelong immunity. You don't have to worry about getting it again. And so why haven't we fully eradicated? We had gotten almost everybody, 98, 99% of people across the globe to be vaccinated. And then in 2014, and you should be thinking about what goes on in 2014. Around 2013, the World Health Organization, UNICEF, whose focus is really on children, and of course trying to eradicate so there's no more paralysis, realized that in some areas in Africa and the Middle East, there were a couple of cases of paralysis. And so we know again that if paralysis shows up and it's polio, that 100 other people or more have it, but of course they don't have the full symptoms. So the point is, we go to eradicate. What do we have to do? We have to get everybody inoculated. But war breaks out, and a number of conflicts happen in a number of these countries, and it's very hard to then go and to do this polio vaccination. Something else happens in 2014, which also interferes with eradication of polio. It's another major epidemic, a global epidemic. Some call it a global pandemic. Does anyone remember what that was in 2014? Anyone have any idea? Anyone? Did anyone? I don't know if anyone's emailed it in. Any guesses? Well, it's Ebola. And so in West Africa, we start seeing Ebola, which we had seen before, by the way, in the 1990s and even before that. And the interesting thing about Ebola, of course, which is much worse than COVID as a disease, 75% of people who get Ebola die. Okay, and we're at less than even 1%. People are calculating for COVID. So it's a very different kind of disease. But what's interesting is that unlike COVID, we've seen these bouts, these epidemics happening with Ebola in certain places, where COVID is totally new. We've never seen it. Our immune systems have never seen this. So when somebody gets COVID, it's a new learning experience totally across the entire population. So it's a totally new disease. But anyway, so we work on, and we get everyone to work on Ebola, and really trying to get Ebola under control. And I don't know if you remember this, but the big worry is, of course, Ebola was happening, and lots of people were getting sick and dying, but more in rural than in city. And our big concern was, if Ebola goes to a big city, then there's going to be massive spread. And we know what massive spread in big, dense cities looks like, having had this now experience with COVID. The good news is that we were able to change human behaviors and stop the spread of Ebola. And while we lost about, I think, 25,000 people, we were able to contain it by, again, we don't have a vaccine for Ebola, or we're working on one now, but at the time we didn't. And so we were able to change human behavior. So public health partners, understanding disease, understanding the way people work in populations, and thinking about how to partner to change human behavior. And so epidemics, I've been through HIV, I've been through some polio. Polio is still, it actually has now reared its ugly head in a number of countries, and we really have to try to get some control of that, and it's hard. Been through Ebola, been through Zika. I don't know if you all remember, only a couple of years ago, Zika, microcephaly, children born with a major neurological deformity, and it was a mosquito-driven. And now, of course, we're at COVID. We could throw in SARS, although we really didn't experience SARS to the same extent that we're experiencing COVID. So what are you learning about this? That diseases are still going to continue to keep happening. Now, there's an interesting thing. What about how this disease gets into a population? How is COVID? What are they thinking about how COVID has gotten into the population initially? And there's similarities there with something like Ebola. And Ebola, we now believe that deforestation, right, in West Africa led to bats having to move to places that were more populated, and little kids, there were bat droppings, and little kids ended up eating the bat droppings. This is what people believe. And so that first case, that pivotal case for Ebola, was again this exchange of a virus from a bat to human, and then there's this spread. And I think for COVID-19, we're seeing the same thing, right? We believe that somehow there's been this exchange of virus from some animal of the wild, or what we would call bush, some bush meat, and then the virus jumps to humans. We've never seen it before. And boom, we have this really serious global pandemic.
Wow, thank you so much, Bernadette. We can sense your passion. We can sense your expertise. I love it. I want to make sure we get through all these questions. Yes, we got about 6 more here. Yes, okay. So I'll just go back to back.
I'll be more succinct in my answer.
No, you're good. We are grateful that you're here with us online this morning. Quick question here. COVID-19, did it surprise you? And what makes the difference then? Or what made it? Yeah, so the students are asking here, how come it caused our government to pretty much shut down, or pretty much our world, in the US at least, to pretty much shut down? Why do you think this is different than the past pandemics?
So if, a couple of things, right? Does it surprise? So there's been this prediction among infectious disease epidemiologists that sooner or later, as we kind of do deforestation, as we bring the wild into sort of urban settings, that we are setting ourselves up for diseases we've never seen before. So that's the first thing. So did it surprise us? No, we've been kind of predicting it, but there are systems in place that we contribute to here in this country, and that the World Health Organization is part of, which is this kind of active surveillance of new infectious diseases. And it's not a political statement. I'm just going to say we need to continue to support this. All right. Any disease that we've never seen before, that our immune system has never seen before, is going to hit badly. So I don't know, think about history lessons, right? The Spaniards come over and they meet the Native Americans in lower US and Central and South America, and in, I guess, the 1400s. What do they bring with them? Anyone know that answer? And why does it kill a huge central a Native American population? They bring smallpox with them. Okay, the smallpox is actually on the blankets that they give to people in trade, and we lose a huge entire population of Native Americans, because their immune system is overwhelmed by having to respond to it. So this isn't the first time this has happened, and it probably won't be the last time. So the second part of that question is, so this has spread. It's spread because we don't have good immunity. It's spread because to this because we've never seen it before. So it's going to take our bodies individually and as a population some time to figure that out. That's one. And it's a very odd disease, right? It takes a long time, in a way, incubation, so no symptoms, then symptoms. And we know that there's shedding of the virus, which means that it's transmissible to other people when you don't even know you have it. And that's the problem, right? And so we closed down because bad things were happening to vulnerable people. They were dying. They were getting very, very sick at a rate that we couldn't control. So how do you do that? How do you stop transmission? You stop human to human interaction, and that's what we did. That's what they did in China, in South Korea, in Japan, in Italy, and in the US. Now, do you want me to stop there? And we can ask more questions. Yeah.
Yeah, I'll keep asking you. Yeah, so the next question is, what are the chances of this happening again? And if you were to make a prediction, when do you think it's going to be over?
Oh gosh. Over, I think it's going to be
Sorry about
really, I think it's going to be really over, meaning that over is going to be defined as us having better control of this and not staying and sheltering in our houses and having to wear masks all the time. I would say 18 months to 20 months, okay, from now, okay? So I know that's tough. This is a new normal for all of you. This is tough. You should know that if you look back at history, that there have been many, many other diseases that have done the same thing. We are not new in staying home. We are not new in quarantine. It's just in your life, and even in my life, we haven't had this kind of quarantine, stay-at-home experience, but our great-great-grandparents have,
Wow.
and generations before. So that's what. So did I finish all the parts of that question?
Yeah, like I'm getting a lot of questions here on testing.
Yeah.
So, what's the leading type of test available to test for COVID-19 right now, and what's the availability of them? And do you expect tests to be available to the general public at some point, like
Yeah.
on a schedule?
Yeah, so great questions. One, we're testing to diagnose the disease. That's with PCR testing. The thing that you need to understand right now, we do not in the state of California have anywhere near the number of tests that we would like to have to be able to start testing people who have mild symptoms or maybe asymptomatic. The diagnostic COVID test that you're seeing everybody doing drive-throughs is to test that you have the virus actively in your system now. We only are giving that to people who have symptoms, okay? And now we've if it increased the number of tests. And now, it used to be that, you literally have to be almost admitted to a hospital before you have that test. Now it's the criteria is expanding. And so that's the first test. The second test that you're hearing more about is antibody testing, right? IgG, IgM, you develop antibodies. Your system has focused on this, immune system is focused on this virus. It now has it's experienced it, and it says, I have soldiers in place to fight this virus. And so the indicators of those soldiers in place, if you will, are IgG and IgM. I'm not going to go fully into that, but the antibody tests will say this individual has experienced this, and we'll give a little bit of time on that. Here's the problem with the antibody tests, okay? COVID-19 is a coronavirus. What's the other well-known coronavirus that we're all talking about? It's actually the common cold. And so we have to develop a test that's able to be sensitive enough to differentiate the fact that you have had a common cold from you have had COVID-19. And that's been difficult. The other thing is that not all viruses provide the same kind of immunity as something like polio virus or even Ebola virus, right? Thinking about influenza, we know that we have immunity and we get vaccinated, but that's not lifetime. In fact, it's really only every year. And I know that it's all about how we predict which flu is going to come up is the kind of vaccine that we get. So antibody testing is getting better. And there are 4, I believe, approved antibody test platforms out there now. At UCI, we are starting an Orange County community-wide antibody serosurveillance study. We want to see how many people have had COVID that have had no symptoms or mild symptoms, because that's going to give us a sense of how much protection in the community, something called herd immunity, that we may have. And so if 98% of a community has had an infection, 2% of that community may not have the infection and may not have the immunity, but that 98% will protect the others, or 95% or 90%. But just so you know, COVID-19 is complicated. It's not clear whether this is going to be something we see annually like the flu. And once we know that, if that was the case, we would probably add the vaccine to the existing flu vaccine, and then we would get each year vaccinated for that. Or if having it once means that you have lifelong immunity. So we're still working on that. You are living through the unknown part, which I told you in HIV there was, in Zika there was. We're living through that now.
This is so educational, Bernadette. Seriously, like this is so good. So talk about Orange County, as you mentioned, like we're going to try these different tests, but how are we doing in terms of Orange County? Like, how are we doing?
So I want to say, and what I'm going to do is I'm just going to send you and for something that the Orange County students may want to look at. I'm going to send you a few slides. I am proud to be in Orange County. As I told you before, I left New York, and poor New York, they really had a lot of problems. So let me tell you the story of Orange County and COVID, which is really interesting. And you're hearing about modeling and all of that. So, COVID becomes something of a reality to all these infectious disease epidemiologists like myself end December, but really early January, right? And then we start seeing cruise ships and in Wuhan, large numbers of people, and it becomes scary. And we know that the world is small because we can travel globally. And so in the United States, the scientists start to say, this is bad, this is going to come here, and how are we going to handle this? Okay. And so we get at UCI actually a team together to really start thinking about that, how to handle students on a large campus, how to think about Orange County as a community. And so we move from how do we prepare, and the first thing in preparedness is vigilance, right? Hand washing is still the very most important thing. We moved from that to not shaking hands. We moved from that, and now we're in February, to thinking about this whole concept of social distancing, stopping the transmission of disease by not being close enough to get it. And so this is early March in Orange County, and we've had basically one person who we knew got it from travel, and maybe we're up to about 5 cases. And in other places, and everyone expects, by the way, California to go first, to hit the surge, to hit, excuse me, the peak, to be in an emergency mode. And when, and to be honest with you, in mid-March, on March 9th, right as the governor is declaring shelter in place, UCI sends everybody home to be remote. We are doing really poorly. We are doing as bad as Italy. In fact, if you're a math person or biology person, our curve, the doubling. So in other words, the virus, the number of cases was doubling every 3 days. It was exponential, and it was the same curve. You could just put it right over the curve for Italy, and we know how bad Italy ended up being. That we were there, we were in dire straits, and it was bad. And this is why I'm proud of Orange County. We went into shutting down when there were only something like 14 cases, okay? And this was critical. We shut down, sheltered in place, shut the schools down. And by March 28th, okay, by March 28th, the curve starts to change. The trajectory, we don't have that doubling anymore. We actually achieved, this social distancing model stopped the rapid transmission of disease and slowed it down. And so overall, we're seeing about 60 or so cases a day. So the cases are still growing in Orange County, but the doubling, the exponential curve leading to this blast of people with coronavirus in Orange County that was predicted initially did not happen. But it did not happen because of everything you have all done. You were part of that community. You helped to shift the curve, to flatten the curve. And that means that people who are sick can get the care they need, can get the ventilators if they need it, can have the ICU service and care. And that's a really important thing. But it means that very few people were probably exposed to the disease. And so when I talked about herd immunity, it means that probably 90% of people in Orange County still have no immunity to that. And so we're going to open up, we're going to watch our cases, the governor's watching, the county health officer's watching. When we start to slow down a little bit more, and that's probably going to happen in May to early June, I bet Memorial Day will be pivotal. We're going to start to let people do some things that they have not been able to do. And it's most important, all of you are ambassadors of health out there. You got to keep control of your parents, and you have to make sure, if we get out there too fast and we stop all the social distancing and we don't wash our hands, that curve is going to come right back up, and we're going to be just like Italy, and we're going to be in a bad place. And so that's where Orange County is now. We are not out of the woods. We stopped something bad from happening. And if we can do the right thing and slowly take steps while still keeping transmission levels very low, we may be able to get ourselves into a good place so that when a vaccine comes in place, we'll be in good shape.
That's all. Wow. Thank you so much. Hey, that's inspiring. Wow. That's awesome. Uh, I'm going to do two more here and then I'm going to open up for the students. But a lot of the questions surrounded vaccinations.
Right.
Okay. So we don't need to get too in depth on this one, but just in general, the current minimum time required for developing a new vaccine is about a year, so maybe a little bit more. What is the process of developing a new vaccine and what needs to be done before widely giving it to everybody? So
Yeah.
that's question.
That's a great question, and I'd love my husband to be here on the phone because that's what he does. He develops drugs in the pharmaceutical industry. Although he's come here to UCI and is helping UCI to be able to do some of that work. So there are three phases to developing a drug: phase one, phase two, phase three. It's actually a phase four. Phase four is called surveillance. So in phase one, you want to make sure that whatever you're developing is safe for humans, right? So even if you have a great idea, even if it works in rats and other animal models, and even if it works in mathematical modeling, we are different. And so what we can handle or not handle is different. So you have to make sure. So one thing is it going to be a live vaccine or is it going to be an attenuated vaccine? And so that's one of the questions. If it's a live vaccine, or is a denatured vaccine is separate than a live. If it's a live vaccine, then what you would do is they would give a little bit of a live virus in just to set up that army of immunity that would be protective. And so one question is, which way are they going to go with this? All right. And is it safe, right? Because you don't want to, maybe you think I'm going to give a little bit, and it turns out that just that little bit overwhelms the immune system, and the people that you give it to, it is going to, they're going to get very sick. So in phase one, it's about safety. Can I give it to people and can it be safe? Phase two is, and if it makes it through phase one, then phase two is about understanding how this works as a vaccine in relation to COVID. And phase three, so that's you do a little bit of what we're going to call a signal of efficacy, a signal of may this work, and how much, what's the dose, okay? So this is really important. And you have different people, different populations of people. You have like normal, healthy young people that get recruited to be part of this in phase one, right? Because they're the people who are least likely to be sick. In phase two, you may increase the distribution of the population to include younger people and older people. And so you're testing a little bit more about the safety. You try to figure out what the dose is and figure out if you can get a signal, is this protective against the virus? And then phase three is, okay, so I use 10 people in phase one and maybe 50 people in phase two, but now I have to get it out. And phase three is actually testing the vaccine against the virus. And that takes some time. And it also, you have to feel secure enough about the vaccine because you're going to expose people to the virus, right? And we don't know fully who's vulnerable to getting very, very sick versus not. And that's phase three. And if phase three shows that there really is, some reduction in virus after exposure, given the vaccine, the Food and Drug Administration, by the way, partners with the pharmaceutical industry the whole way, then they give the red light to get that out. Now, in other epidemics like HIV, we were able to get treatments out earlier than the normal years and years and years of testing. It's probably 7 to 10 years in a regular drug. And that's because we don't want to get something out there that's going to be harmful to you. But we know we are in a bad scenario. And so we need to get this out. And people are already doing some early testing, not only on vaccines, but also on therapeutic agents that may help people get through this without as many bad outcomes. So hopefully that helped. The final phase is phase four. So in phase three, if that looks good and you've got a lot of people, that's usually like a couple of hundred to a couple of thousand people have to be part of that. If it gets approved, it is out and distributed. Phase 4, though, is surveillance. So even after the vaccine is out, in phase 4, you want to say, is there something I missed in phase 1, 2, and 3? Are there people that somehow this vaccine does different things too? And so phase 4 is surveillance, and it's watching how everybody uptakes this vaccine and how it moves through the population.
Wow. Students, are you inspired or what? So many students, Bernadette, at our school.
Students are inspired by you,
So
Chow,
many
your
students,
enthusiasm.
so many students, Bernadette, at our school are just really interested in medicine, and that's why we started our program. But I think after this talk, I think a lot of them are going to be now interested in public health, physician, public health, epidemiology. Like, what would you say are the major differences? And yeah, so
Absolutely. So the major big difference is clinicians, physicians, MDs really focus on the health of the individual. You know, the primary role is to treat the individual person in the office every day. Okay. And your treatment is basically dictated by the evidence that is out there. In public health, we focus on the health of populations, of communities, of people. We're critical in thinking about the evidence that the clinician uses to treat the patient. But we're really about, so a global pandemic is a public health issue. We are there at the beginning, as some public health folks or some epidemiologists do molecular epidemiology, and they're involved in asking the question, where did COVID really originate from? Did it really originate from China? When did it come to the United States? There's a way to look at the genetics of the virus. And so, I think you heard that most of the COVID from New York actually came through Europe. And more of the COVID in Seattle came from the Asian continent. And so that's what a molecular epidemiologist would do, describe that in populations. An epidemiologist like me is really looking at I'm really interested in the intersection of disease and community behaviors. And then there's other people that are interested in environmental health and public health. And so there's many different things you can do in public health. You can be an MD and do public health, an MD and an MPH. But, I was more interested in populations and didn't want to treat individuals, but really wanted to look at populations. So that's the big difference. But of course, everyone's interested in science, everyone's interested in health, and so we really come together as a community.
wow, love it. All right, so now we're going to get to the students' questions here.
Yeah,
And,
sorry.
yeah, but just one last one for me: SoCal or New York, Bernadette?
So cow, I can leave it as.
All right. Hey, like I'm seeing some questions pop up via email right now and on the YouTube Live. And I do want to say thank you to Sahina. Sahina has a lot of intricate questions here. And if we don't get through all of them, I will email them to Dr. Boden-Albala.
And I'll answer them.
Answer them. But her first question I really like. It says liquid gold or donated plasma from recovered patients. Like, we've been hearing a lot of talk about this.
Right.
So what is the criteria to donate plasma? And really, for those viewers who don't know what that is, like, can you just briefly explain kind of what she's kind of leading to in this question?
Sure. So, so liquid gold or plasma, that's the therapeutic, the way in which we're trying to treat the most patients that seem to have the poorest prognosis. So remember, I talked about how when you get exposed to a virus, you develop this immune response, right? And that immune response has to do with a number of different kinds of blood cells being able to attack. So plasma is able to harvest the individual's white blood cell or immune response. And if you give it to somebody else, it can help that person when their immune system isn't responding or is overloaded. And so it's like taking soldiers to fight a battle and bringing them into another battle to fight. That would be another individual. So that is something we're doing. One of the things, though, is that we're using that to help the most ill, and those would be people who've had documented cases of COVID-19 already and have built up an immunity. But we might want to step back and see how that works in earlier cases, because that would be, and that's something that people are looking at. What's the best timing to give this plasma?
Wow. Thank you so much for that. I'm getting so I just got an email here. I'm not going to say the name for privacy reasons, but Dr. Boden-Albala, thank you so much for your talk. I am 14 and I'm in AP biology. Is there anything I can do to help?
Oh, well,
I love that question.
I was just talking, well, there probably are a lot of things you could do. The first thing, I'm the biggest promoter. I was a big science researcher when I was in high school. Both my daughters in high school were Intel, ISEF, semifinalists, finalists. Your passion starts now, and there are so many things that you can do. And I know you probably have a great science research program there, but you should feel free to reach out to the champions in your mind of whether it's COVID or heart disease or cancer, and start doing your research now. Start building that passion and that knowledge base. And Mr. Chow and I were talking, and we're going to try to get something in place where we can expose all of you to some passionate researchers in public health.
Love it. Thank you oh my goodness. Your connection is invaluable to us. Here's another one. What can we learn from this pandemic, and what can we do to prepare for the next health crisis?
Yeah. So I think we need really good surveillance, right? So one of the great things that we can learn is that we can change people's behaviors, right? We learned it from Ebola. We're learning it now. So there's tremendous power in community, and you should know that we have that power. And if we can just, hone in on that power, we can make some real changes. So I think surveillance, I think understanding how we are behaving in this, so that we can make recommendations for the next one. And of course, we can learn a lot more about immunology, which we don't have as much of a handle on, since we still don't know a lot about the immunity or immune response to COVID.
Wow. And I want to give you a little time right now to plug your new school of public health, apparently.
Yeah, thank you. So you should just know a couple of things about UCI and public health. And I came here to be the founding dean, to move from a very, very good program in public health to a school of public health. And right now, UCI has one of the strongest and nationally recognized and largest undergraduate programs in public health. We have 1,300 undergraduates right now, and we are really excited. Think about, if you're interested in public health, start early, start as an undergraduate. Not a lot of schools have that program, but they're building them, and we're a great program. And we have a master's degree. The MPH is a master in public health. It's a terminal degree, which means that it's like an RN, people with an MPH, they're running large programs around nationally, domestically, and globally. And then we also have a PhD program if you're really interested in one specific area. And it's not, so say you like science, but you love history more. I have a great historian, Dr. Andrew Neumer, and his whole life has been focused on reading and understanding pandemics. And he's used everything that he's read to help us to prepare and understand this one. So even the history buffs who like science, there's a place for you in public health.
Wow. I'm telling you, I'm encouraged right now. Like, this is great. I'm going to give you one last platform right now to just say to all of our high school students, your best life advice. Like as we come to a close. And once again, if I didn't get to your questions, I'm going to email them to Dr.
My
Boden-Albala.
best,
But
yeah.
just finishing
My
up here.
best, I think my best life advice is learn everything you can about everything. So that use every opportunity. You're home with your families. It can be a little bit difficult. I know. I'm home too with mine. Learn everything. And just think about, that this is a great part of your life to take everything in. Second thing is go with your passion. You want to ultimately, even if that means disappointing your mother or father a little bit, they'll get over it because they'll see your passion. Could take a few years, but that's what being an adult means. And then the third thing I'm going to say, and I don't want to be political at all, but know that each of you is responsible for the future, and so choose leadership wisely at your school level, at the local level, at the national level, because when we're in crisis, it's leadership that has to come in and help. And so that's most important. But passion, passion, passion. I'm passionate about infectious disease epi. And, that's why I'm here and feeling that we can really help because I have passion. So don't throw your passions away.
Bernadette, from all of us to you, thank you so much for just taking your time to tune in with us this morning to talk about COVID. You are just a great person. You're a great professor. You're a great educator. You're a great communicator. You are just so good at what you do. And my greatest hope is that my students can have that same passion that you do for.
Oh, I believe all of you will have that same passion.